This seminar is for educational purposes only. It is not a substitute for professional medical advice or treatment. Consult with your medical provider for medical advice or treatment. Although the presenters try to keep the information in this seminar as accurate and timely as possible, the speakers and Mather Hospital assume no duty to ensure the seminar is error-free. The speakers and Mather Hospital are not responsible or liable for any claim, loss, or damage resulting from you viewing this seminar.
Good afternoon, and thank you for joining us today for our HealthyU webinar series. Today's webinar is the role of the HPV vaccine in preventing different cancers, and is sponsored by New York Cancer and Blood Specialists. At any time during the presentation, please feel free to enter any questions you may have using the Q&A feature at the bottom of your screen. We will answer as many questions as we can within the time allotted once the presentation concludes. Your questions will also remain anonymous as always, and today's presenter is Dr. Melissa Nicosia. Dr. Nicosia is a board-certified gynecologic surgeon and has extensive clinical expertise in vaginal, laparoscopic, robotic, and hysteroscopic surgery. She has performed procedures on various benign gynecologic conditions, including fibroids, abnormal bleeding, endometriosis, pelvic pain, and pelvic organ prolapse. Prior to joining Mather, Dr. Nicosia was the director of gynecology at Woodhull Hospital in Brooklyn, New York, and an assistant clinical professor of obstetrics and gynecology at NYU. During this time, she improved access to minimally invasive surgical options for women and received the Excellence in Innovation Award. She is published in peer-reviewed journals and presented nationally and internationally on an array of women's health topics. Dr. Nicosia received a Bachelor of Science degree in Biosystems Engineering from Clemson University in Clemson, South Carolina, and received a medical degree from Georgetown University School of Medicine. She completed her internship and residency in obstetrics and gynecology at NYU Langone Medical Center in New York City, where she was administrative chief resident. She completed a fellowship in minimally invasive gynecologic surgery at Virginia Mason Medical Center and is a member of the American Congress of Obstetricians and Gynecologists and the American Association of Gynecologic Laparoscopists. Dr. Nicosia is the director of Mather Hospital's Department of Obstetrics and Gynecology and practices at Northwell Health Physician Partners Obstetrics and Gynecology in Port Jefferson. You can go ahead and get us started, Dr. Nicosia. How are you?
Hi, thank you for having me. Good afternoon, everyone. I'm Dr. Melissa Nicosia. I am a gynecologist here in Port Jefferson, as she mentioned, and I do specialize in robotic and laparoscopic surgery. I'm the director of OBGYN at Mather here, and my office is across the street from the hospital. So you may run into me at some point, as I do spend a lot of my time either seeing patients in the office or seeing patients in the hospital, as well as performing surgery at Mather. So I'm around a lot. I'm privileged to be here today and to be able to discuss an important topic, which is the HPV vaccine and its role in the prevention of cancer. You may or may not be familiar with the HPV vaccine, so I'm hoping to provide you with a lot of information on why this vaccine, which is the only vaccine that's been shown to prevent cancer, is so important. So to start off, let's just first discuss what is HPV, or human papillomavirus. It is a virus that's most commonly sexually transmitted. It is the most common sexually transmitted agent in the United States. There are more than 200 different types of HPV and approximately 40 types that are spread through direct sexual contact. Condoms can lower the chance of HPV transmission, but do not prevent it completely. There are different HPV types that have a propensity to infect different body sites and are thus associated with different diseases. Certain HPV types have a predilection for the skin and can be found in plantar warts, common warts, flat warts, which many of you may be familiar with. And some HPV types are more commonly seen in what we call the anogenital area. So this includes in men, the penis and the scrotum, the perineum in men and women, and in women, the vagina, the vulva, and the cervix. And some types can also infect the lining in the oral cavity, which we'll discuss as well. In terms of different risk types for HPV infection, there are low risk types and high risk types. So the low risk types of HPV mostly cause no serious disease. However, there are a few low risk HPV types that can cause warts on or around the genitals, anus, mouth, or throat, and that can be very bothersome to patients. High risk HPVs can cause several types of cancer, so that's what we're mainly going to be focusing on today. There's about 14 high risk HPV types, and 2 of these, which are called HPV 16 and 18, which we will discuss, are responsible for the majority of the HPV-related cancers. It is important to know that HPV infection is very common. Nearly all sexually active people are infected with HPV within months to a few years of becoming sexually active, and around half of these infections are with a high-risk HPV type. HPV can infect both males and females, and both men and women can also develop HPV-related cancers. It's also very important to know that despite the fact that it's very common, most HPV infections do not cause cancer, as your immune system usually controls the HPV infections and are able to clear the virus from your system. When a high-risk HPV infection persists for many years, typically 10 to 20 years, it can lead to cell changes that, if left untreated, may get worse over time and become cancer. So this is the focus again of our discussion today. The HPV itself infects cells that are called squamous cells in the body. And these are a type of cell that lines the inner surfaces of specific organs, like the organs that we were previously discussing. And for this reason, most HPV-related cancers are a type of cancer that's called squamous cell carcinoma. Most HPV infections, including those types with cancer potential, typically are transient, like I said, and resolve within 12 to 24 months. However, the HPV types with cancer potential that persist beyond the 12 months do increase the likelihood of precancerous or cancerous lesions, although not all persistent infections progress. HPV has also been shown to enter a latent state or a dormant state in the body where it remains dormant. That in some populations, there can be reactivation of the virus. So what are some risk factors for people acquiring HPV infection and progression to HPV-related cancer? So just in terms of risk factors in general of the infection, those are younger, anything where we're increasing the risk of exposure to different HPV types. So that includes younger age at intercourse, a greater number of sexual partners, inconsistent condom use. Smoking is, as we know, is bad for many reasons. But in particular, with regards to HPV, it has been shown to decrease the risk of clearing the infection and also can increase the risk of progression to cancer. So there is definitely a link between smoking and progression to cancer in these patients. A history of other sexually transmitted infections like gonorrhea or chlamydia also increases the risk of HPV. Patients who are infected with HIV have increased risk of HPV, as well as decreasing the rate of clearance and increasing the risk of progression as your body is in an immunocompromised state. Other immunocompromising conditions can also increase the risk of the ability to clear the virus and as well as increase the risk of a progression. And finally, persistent HPV infection, as we spoke about, it does increase the risk of progression to cancer. So in looking at the low risk types that we spoke about, HPV 6 and 11 are responsible for approximately 90% of genital warts in men and women. And HPV 16 and 18 are responsible, which are the high risk types, are responsible for about 70% of cervical cancers, in addition to some other types of cancers, which we will discuss. HPV, there's other types that are HPV 31, 33, 45, 52, 58, and some other high-risk HPVs that are responsible for about 10 to 20% of cervical cancer. So about 90% of all cervical cancers are due to HPV. So wouldn't it be great if we could prevent HPV and then prevent cervical cancer? And that is what we're here to discuss, which is the HPV vaccine, which is a way to do that. There are approximately a dozen high-risk HPV types that are responsible for all HPV-related cancers. In the US, HPV is responsible for 3% of all cancers in women and about 2% of all cancers in men. Worldwide, the burden of HPV is much greater, and high-risk HPVs cause about 5% of all cancers worldwide, with an estimated 570,000 women and 60,000 men getting an HPV-related cancer each year. So pretty significant. Cervical cancer is among the most common cancers and is a leading cause of cancer-related deaths in low and middle income countries. And this is because screening tests and treatment of early cervical cell changes are not readily available in these countries. HPV has also been linked to anal cancer, cancer of the oropharynx or the back of the mouth, penile cancer, vulvar, and vaginal cancer. So let's take a look at some of these specific cancers. As we discussed earlier, over 90% of cervical cancer is caused by HPV. The cervical cancer is considered a preventable disease because it is the only cancer in this group of cancers that we're discussing where we have screening available. And that is pap smears at regular screening intervals, as well as HPV testing. And we do have treatment options available where we can remove precancerous cells before they progress to cancer. Most cervical cancer occurs when the patients do not have regular care or regular follow-up. So as long as patients are getting pap smears at regular screening intervals, this is a preventable cancer. Because of our ability to screen in the US and because of the introduction to the vaccine, the rates are decreasing in the US. However, it still remains a leading cause of cancer-related death in low and middle income countries because of this lack of screening, lack of availability of treatment in these countries. So the oropharynx is basically the back of the throat. Most of these cancers, which develop in the tonsils or the back of the tongue, are caused by HPV. 70% are caused by the HPV in the US, and the majority of those are linked to HPV 16 and 18. Unlike the cervical cancer, where the number of cases is going down, the number of new cases in oropharyngeal cancers is actually increasing. And it is now considered the most common HPV-related cancer in the United States, with a lifetime risk of about 1.2%. So still pretty rare, but now more common than cervical cancer. About 90% of cancers of the anus are caused by HPV, again, predominantly 16 and 18. Just like the oropharyngeal cancers, the number of new cases and deaths from anal cancer are increasing each year. As you can see from this chart, anal cancer is twice as common in women as it is in men, and it's pretty rare with a lifetime risk of 0.2%. And looking at cancer of the penis, the vagina, and the vulva, HPV is responsible for 60% of cancer in the penis. Again, HPV 16 and 18, the most common types. Again, this is a very rare type of cancer. Vaginal cancer, about 75% is caused by HPV. Again, 16 and 18 being the predominant types, also very rare. In vulvar cancer, about 70% is caused by HPV, with the predominant types again being 16 and 18. So what is the big deal? Why do we care about this? Most of these cancers are rare. Why is this such a big deal? First of all, as we discussed before, it is a very common infection. It's very easily transmitted among partners. In addition, the infection with the high-risk HPV does not usually cause symptoms. And aside from cervical cancer, there's very limited options to screen for HPV in these organs and for treatment to prevent the progression to cancer. So most of the time, by the time it's picked up, it's already cancer, which can have a poor prognosis and can be fatal. You know, these cancers do typically take a long time to progress. So on the average, it takes about 10 to 20 years. Currently, cervical cancer is the only HPV-caused cancer for which there's FDA-approved screening test available. Screening for cervical cancer is an important part of our routine healthcare for people who have a cervix. It's a regular part of a well woman visit. This includes women and transgender men who still have a cervix. Cervical cancer screening tests include the HPV test that checks for cervical cells for high-risk HPV, as well as the pap test that checks for cervical cell changes that can be caused by the high-risk HPV. There are no FDA-approved tests for detecting HPV infections or HPV-caused cell changes in the anal, vulvar, vaginal, penile, or oropharyngeal tissues. So all of those other cancer organs that we discussed. There are a lot of research studies ongoing to identify these tests that can detect these precancers, so that we can detect them and find cancer in an earlier, more treatable stage. But that is definitely one of the problems, is that by the time it's diagnosed, it's not too late, but there may be limited treatment options available at that point. So if we cannot screen well for HPV and HPV-related cancers, then it's very difficult to treat the problems before it becomes a cancer. But if we could prevent infection with a vaccine, then we wouldn't need to worry so much about the lack of screening and the treatment of the precancerous cells. So this is where the HPV vaccine comes into play, and what we'll be spending the rest of our time talking about today. So in the vaccine world, the HPV vaccine is a relatively recent and new vaccine. It was first introduced by the company Merck in 2006, known as Gardasil. At the time, it was a quadrivalent vaccine, meaning that it prevented 4 different types of HPV, which were 6 and 11, which, as we discussed, is predominantly responsible for genital warts, and 16 and 18, which is the more concerning HPV types that are found in a lot of the HPV-related cancers. At the time that it was introduced, it was indicated for men and women aged 9 to 26, as that was the age group for which the vaccine studies were conducted. In 2009, GlaxoSmithKline came out with another HPV vaccine called Cervarix, which you may have heard of before, which is a bivalent vaccine. So it prevented 2 types of HPV, which were HPV 16 and 18. It was also recommended for the same age groups. However, it was discontinued shortly after release, a couple years later, due to a low market demand, given that there were that there was a very similar vaccine already on the market that covered more strains of the HPV virus. In 2014, Merck introduced the Gardasil 9, which is currently the only HPV vaccine that's available in the US. It protects against infection from 9 different types, which are the ones listed here. So 6, 11, 16, 18, 31, 33, 45, 52, and 58. The 2 low-risk HPV types that cause most genital warts, plus the 7 high-risk HPV types that cause most HPV-related cancers. It is estimated to prevent up to 90% of HPV-related cancers. It is important to discuss that this is a prophylactic vaccine. It's a preventative vaccine. It prevents infection. It is not a therapeutic vaccine. It has not been used to be effective in treating HPV infection or disease. However, there are some ongoing studies, particularly in cervical cancer and precancerous cells in the cervix, looking at giving patients the vaccine after they've been treated for these precancerous cells. And there's some preliminary data actually showing a decreased risk of recurrence. So there is some promising information with regards to it possibly being a therapeutic in the future. Because it prevents viruses that are sexually transmitted, it offers the most protection when given prior to the onset of any type of sexual activity. So that leads me to the next topic, which is who should be getting the HPV vaccine. The Advisory Committee on Immunization Practices is the one who makes the guidelines on vaccinations. It is currently approved for use in men and women ages 9 to 45. And this is relatively recent change. It used to be 9 to 26, just as the other vaccines in the past. But in 2018, the recommendation age was extended to 27 to 45 after newer data showed efficacy in this age group. The optimal timing for the HPV vaccine is prior to the onset of sexual activity. Clinical trial data of vaccine efficacy and males and females suggest that the immunization with the HPV vaccine is most effective among individuals who have not been infected with HPV previously. Studies have also shown lower cancer rates in patients who are vaccinated earlier, specifically younger than age 17. Therefore, the recommended age for girls and boys is age 11 and 12, with the ability to start as early as 9. For adults through age 26 who were not vaccinated in the past or who haven't completed the series, it is recommended to give them the vaccine or to complete the series. So for those adults that are older than 27, catch-up vaccination, or say that they started it in the past but they didn't complete the series, is not routinely recommended. They also note that the decision to vaccinate people in this age group should be made on an individual basis. And that's because the likelihood of prior exposure to HPV vaccine and the HPV types increases with age. So chances are, these patients have been exposed to one or two or maybe more than two types of HPV at that point, and the population benefit and cost effectiveness of HPV vaccination is lower among older patients. Individuals who are sexually active should still be vaccinated consistent with age specific recommendations. A history of abnormal Pap test, Pap smear, genital warts, or HPV infection in the past does not mean that you cannot get the HPV vaccine. However, it may be less beneficial for those who have already been infected with one or more HPV vaccine types. But it can still provide protection against infection with the HPV types that you haven't already been exposed to or haven't acquired. Chances are you have not been exposed to all 9 that are covered in the vaccine. But they have been, these patients should be advised that the vaccine will have no therapeutic effect on the pre-existing infection or HPV-associated disease, still to be determined as in these recent studies that I suggested. So when the vaccine first came out, and even currently, there was a lot of concern about, why should we be vaccinating 12-year-olds against a sexual infection? Are we going to be causing, 12-year-olds to become more promiscuous or to start having sex earlier if we vaccinate them against a sexual infection? So, there was a lot of misunderstanding around this. As we discussed, in order for the vaccine to have the highest efficacy, it must be given before the potential exposure and infection with HPV, which coincides with the onset of sexual activity. There have been studies that have shown that 20% of 9th graders, so around age 13, 14, 15, and more than 55% of 12th graders have engaged in sexual activity. So the reality of the situation is that we do need to vaccinate them before these ages to really capture the highest number of people who haven't been sexually active yet. And this doesn't just include penetrative intercourse. The vaccine is also more effective when given at earlier ages, and that's been shown with the data, regardless of when sexual activity occurs. So there was a large study in Sweden that looked at vaccine effectiveness in preventing genital warts, and they saw a 93% prevention rate in girls vaccinated between ages 10 to 13, compared to significantly lower rates in women, that were older in 20 to 22, only 40%. And only 20% effective in girls vaccinated between ages 23 to 26. There's also been some concern, like I said, that the HPV vaccine to a young girl or boy may make them more likely to become sexually active. This is simply not true. They've done studies looking at that, and they have not shown that HPV vaccination would be associated with an earlier onset of activity or increased incidence of sexually transmitted infections. So for those patients who are older than 26, an individualized approach is recommended, given many at this age have already been exposed and the vaccine may not be as effective as I mentioned. However, there are some individuals in this age group, such as those who have not had prior sexual experience or with a limited number of prior sexual partners, where the risk of prior HPV exposure may be low. So we do offer HPV vaccination and encourage it in these individuals if they are deemed to have future risk of HPV exposure, such as with expected new sexual partners in the future. Although supporting data is limited, we do also suggest HPV vaccination for healthcare workers who may be at risk for occupational exposure to HPV. So obstetrics and, OBGYNs who are doing these procedures to remove portions of the cervix, to remove these abnormal cells, can be exposed to HPV fumes. And those healthcare workers should be vaccinated even if they're older than 26. So if there are patients that, are in monogamous relationships, they're married, they're not intending to change partners in the future, and they don't have this history of, a large number of sexual partners, those patients, at this age may not need to be vaccinated, and it may not need to be recommended for those patients. In terms of who should not get the vaccine, For anybody that's ever had a life-threatening allergic reaction to any ingredient of the HPV vaccine, which would be pretty rare, or if they've had a previous reaction to a previous dose, because there is more than one dose of the vaccine that's given, which we'll discuss, those patients should not get the HPV vaccine. Their yeast is part of the components of the vaccine. So if they have an allergy to yeast, they should not get the vaccine. And also if they're pregnant. HPV vaccine is not a live vaccine. The reality is that it's probably safe, but there's been no studies done in pregnant women for obvious reasons. And, data from the inadvertent use. So if somebody gets the vaccine and they happen to be unknowingly pregnant, all that data is very reassuring. There have not been shown to be abnormalities, but at this time, it's still not recommended for women who are pregnant. If they started the vaccine before the pregnancy, they can continue it after the pregnancy. It is safe in breastfeeding. But the remainder of the series should be delayed until the patient is no longer pregnant. HPV vaccines are safe for children who are mildly ill, if they have like a low-grade fever or something like that, but people who are seriously ill should definitely wait until they feel better before getting this vaccine, and really most vaccines. So how is the HPV vaccine given? It's given usually in the arm. It's an intramuscular, so it goes in the muscle injection. In the US, the dosing schedule depends on the age of the patient when it started. So for individuals that are initiating the series before the age of 15, it's 2 doses that should be given 6 to 12 months apart. For individuals that are older than 15, there's 3 doses that should be given, and usually at 0, 2, and 6 months. So within 6 months, you will get all of 3 doses. The studies have found that the 2 vaccine doses in the young individuals actually have similar or better efficacy compared to the 3 doses. So again, further reason for getting it done earlier. 3 doses of the vaccine are still recommended for individuals age 15 and older because of this lower immunologic response. So there are questions that come up about what should be done if someone started the series in the past. Do they need to restart the series? What if they got the old vaccine that's now been discontinued, or if they didn't complete the series? So in general, it's better to have the same formulation that's used to complete the series if possible. But if that's not possible, let's say that they got the old Gardasil vaccine for the first dose, then you can give them the newer vaccine, and you don't need to restart the series. So that's very helpful, so patients don't have to get additional doses that may not be necessary. They may forget to follow up on the vaccine. They may forget. So it is recommended that if the vaccine series is interrupted at any time, you can just pick up where you left off. You don't need to start over. If they're older than 15, but they started before 15, they still need to do the 3 doses, not the 2. So those are some questions that can kind of come up during this transition period to the newer vaccine. Because it is a relatively recent vaccine, and because it does take many years for the HPV infection to become precancerous cells and then cancer, studies are still being done to see how long the vaccine is effective for, and protective, and whether there's any need for a booster vaccine. Currently, it has been shown that the vaccine is considered effective for at least 12 years, and protection has remained very high with no evidence of decreasing over time. So there's currently no indication for a need for a booster vaccine. Again, you don't need to revaccinate with Gardasil 9 if another HPV vaccine series was previously used. It's also been, the prior vaccines have been shown to be extremely effective as well. So if you completed the series with the old vaccines, you don't need to get the new vaccine series at all. In terms of side effects, this is a very well-tolerated vaccine. I've actually never seen a serious reaction from any of my patients from getting the Gardasil vaccine, which we give very often. So serious side effects are very rare. The most common side effects are injection site swelling. Some people get pain at the injection site or redness. Fainting or syncope is not really specific to the Gardasil vaccine. It can happen with a lot of vaccines. So it is recommended to have patients wait for 15 minutes in the office after the vaccine is given, just to make sure that they're observed, and so that they don't faint, after they leave the office or injure themselves. So how effective is this in preventing infection and preventing cancer? So first, the HPV vaccine, the older ones and the newest ones it's important to note that they're among the most effective vaccines available on the market of any vaccine. They've been found to be more than 99% effective in preventing HPV infection with the specific HPV types when administered to women prior to HPV exposure. It significantly reduces the incidence of anogenital cancer and genital warts in women and men. Most of the available studies have looked predominantly at cervical cancer, so we have less data looking at the other types of cancer, but it has been shown to be 97% effective in preventing precancerous conditions in the cervix, vagina, and vulva, in a large international study that was looking at young women. It has also been shown to decrease the risk of HPV infection in the oral cavity, so it will likely decrease the incidence of the oropharyngeal cancer, but those studies are still ongoing. In the US, the prevalence of any type of HPV infection covered in the vaccine has decreased 71%. So that's very significant among women ages 14 to 19 between 2006, when the first HPV vaccine was introduced, and 2014. Since HPV vaccination was first recommended in 2006, the infections with HPV types that cause most HPV cancers and genital warts have dropped 88% among teen girls and 81% among young adult women. Fewer teens and young adults are getting genital warts, which is great. And HPV vaccination has also reduced the number of cases of precancers of the cervix in young women. So part of the reason why these cancers are decreasing in the US. Data informing the impact of the HPV vaccine on oral diseases are limited to studies demonstrating just a reduction in the oral HPV infection, which was estimated to be about a 93% decrease. So that's excellent. But whether this actually has been shown to result in decreased rates of cancer is still yet to be determined. However, with the information of how effective it was at preventing cervical cancer, the FDA did grant accelerated approval of the HPV vaccine for prevention of oropharyngeal cancer and other head and neck cancers caused by the HPV vaccine, based on this effectiveness in prior cancers that has been well studied. So one of the issues is that despite the very high efficacy of the vaccine when given, the vaccination rates are very unacceptably low in the US compared to other countries who have incorporated it into their national vaccination program. So places like Sweden and Australia that have much higher vaccination rates are seeing much better prevention of HPV infection and HPV-related cancers. In the US, only about 54% of women and 49% of men in the recommended age groups have received all recommended doses. So this is very low for a vaccine that's considered very effective. The CDC estimates that if we could increase the vaccination rates to 80% in the target age range, that an additional 53,000 cases of cervical cancer could be prevented. And for every year that the HPV vaccination rates don't increase, that an additional 4,400 women will develop cervical cancer, which is a preventable cancer, as we discussed. So why is this happening? What can we do better? So we know that the high rates of HPV vaccination will reduce the burden of HPV-related disease in the United States. And some surveys where they asked parents who did not intend to have their daughters vaccinated, they wanted to know what were their reasons. And the top reasons were feeling that the vaccine wasn't necessary, the vaccine wasn't recommended by their providers. So some, education between the physicians and the patients, concern about the safety of the vaccine, lack of knowledge about the vaccine or the disease, or the fact that their daughter or son wasn't sexually active yet, so they didn't feel like it was necessary. So this really highlights the lack of understanding of the rationale for the HPV vaccine, and the part of the parent or the caregiver and the important role of us as healthcare providers and really consistently and clearly educating our parents and caregivers about the vaccine. Studies have shown that physicians' recommendations have the strongest influence in the acceptance of the HPV vaccine and providing our patients and the parents with as much information as possible so that they feel comfortable and understand the reason for vaccination. So we must improve the education on the benefits as well as the safety of the vaccine. It's also important to make sure that we stock and administer the vaccine in the offices where available to really improve access to patients and ability to give it during their visits, where we can capture them versus having them have to come back for additional visits. So this is really important in primary care offices. Pediatricians have the unique opportunity for being able to educate patients and parents to initiate the series in the target age range. Family medicine providers, internal medicine providers, OBGYN providers are also crucial in capturing patients who need the catch-up doses to improve adherence to completing the series. So in conclusion, HPV is a very common sexually transmitted virus. It is a major cause of many cancers where there is little to no screening or treatment options of precancerous cells before the progression to cancer. HPV vaccine is safe and effective in reducing HPV vaccine and HPV-related cancer, and it is most effective when given prior to the onset of sexual activity. By improving our vaccination rates, we can prevent many cancers and save lives. I hope that this has been useful for you in terms of obtaining more information about the HPV vaccine and the benefits of it. And I'm happy to take any questions that anybody has. Thank you.
Thank you so much, Dr. Nicosia. That was an incredibly informative presentation. Like she said, if you do have any questions you'd like to ask, please do so in the Q&A spot at the bottom of your screen. We'll wait a couple of seconds for you to enter any that you may have. Dr. Nicosia, maybe you could discuss what it would be like if somebody did decide or did have any questions they wanted to ask you. Would they make an appointment with your office? Is that something you take over the phone? You know, if anybody wanted to see you personally.
Yeah, so usually the best thing to do is to make an appointment in our office. Like I said, we do a lot of HPV vaccinations in our office for usually patients that are above 16 or 18. And obviously I only see women, but we have a lot of family medicine practitioners and pediatricians in the community too that oftentimes do provide the vaccine in their office as well.
Okay, great. It doesn't look like we do have any questions, but I would like to encourage everybody, you'll be receiving a survey. We'd just like to hear more about the topics you'd like to learn more about. Could give any feedback to Dr. Nicosia, and everybody can just enjoy the rest of your day. Thank you so much for joining us.
Thank you so much. Take care.